But now let's move on to the second speaker. Professor Dershwitz is going to lecture us on a bit of a strange title, I thought. In the beginning, it took me some time to figure out what this was going to be about. But you have provided us with a fine abstract, which is in the online, which is available online. So we are going to talking about solutions for problem solutions. Dr. Dershwitz, the floor is yours.
Good morning. So thank you to ISAP for inviting me, and thanks to Tom Kretschi, who suggested that we should have a talk that was chemically oriented on how to solubilize things that are impossible to solubilize. So I have no disclosures based upon the current definition of disclosures, but I will tell you some stories later. A long time ago, I was a consultant to a company that was called Advanced Medicine, and later they changed their name to Theravance, and I was working with them on a project that didn't work, but then we started talking about what other needs there were in anesthesia, and I was lucky enough to participate in the invention of a drug that they call THRX-918661, which is now called AZT3043, and I'm going to spend some time talking about this at in the end. So my definition of a problem solution is something, first of all, where you can't get it into solution at all, or that the solution's a pain in the neck to use, or the solution hurts somebody. And the drugs that I'm going to talk about, dantrolene, acetaminophen, ibuprofen, diclofenac, ALPHAXALONE, and propanidid, I wish I could make that thing go away, all of these meet my definition of a problem solution in one way or another. I tried it, but then that got rid of the full screen mode. But wait, let's see if I go like this. Unfortunately, I don't know anything about using a Mac.
It will explode. It will explode.
Oh, that's better. Thank you. So first of all, dantrolene. Dantrolene was first discovered to have utility in MH in the mid 70s, and I'm actually old enough to remember when people would take the oral capsules and empty the powder into a beaker, add a bunch of mannitol, add a whole lot of sodium hydroxide, and then beat the hell out of it to try to get it into solution. In the late 70s, the company actually marketed the IV version of dantrolene, which was called Dantrium. And in a very large vial, a 70 milliliter vial, they put lyophilized dantrolene 20 milligrams and 3 grams of mannitol and some sodium hydroxide, and you added 60 mils of preservative-free water, and then you shook, and danced around for a while. And after a while, it went into solution, and then you withdrew it into a 60 mil syringe. And then if you were treating the average MH patient, you did that 10, 15, 20 times. So you obviously needed a lot of help. And within the last year, a very creative new product called Ryanodex has been brought to market. And in one very small vial, they put 250 milligrams of dantrolene, a little bit of mannitol, and some detergents that actually get this stuff into solution quite well, polysorbate and povidone. And you add 5 mils of water, it goes into solution very well, and it is perfectly okay to give this stuff IV push when you're in a hurry. So if we take the average 80 kilogram slob who is going to have an MH episode and assume that we might be able to reverse this with 3 milligrams per kilo, if we were using the older solution of Dantrium, it would take 12 vials, 720 milliliters of preservative-free water, and we'd spend about $800. With the new preparation, we have one 5 milliliter vial that we can give over a couple of seconds, and that costs us about $2,300. The other thing that's really important to keep in mind is during an MH episode, of course, it's very important to maintain urine flow because of the myoglobinuria that's going to be occurring. And when you're giving the old version of dantrolene, there's a whole lot of mannitol in there that comes along with the ride, and that's going to induce a brisk diuresis. When you're using Ryanodex, it's very important to give a lot of exogenous mannitol in addition to the dantrolene in order to maintain that diuresis. And in addition, because there's so much in one vial, if you had to, for example, go to 4 milligrams per kilo, there's the potential for a lot of waste. But if you're in a hurry, there is, I think you can make an argument for using the preparation, which is a lot easier to put together. And I can tell you that in my institution, we've exclusively switched to the new preparation, and because of the frequency with which MH occurs, we haven't used it yet. And statistically speaking, what will probably happen is sometimes next year or the year after, we will throw out tens of thousands of dollars of the stuff, but we'll feel better about it. So I think this does represent a solution to a problem solution. The next drug on my list is acetaminophen. And of course, acetaminophen has been popular, even though it was invented well over 100 years ago, it's been popular as an analgesic since the 1950s. And in the United States, we never really had a parenteral product until recently. In Europe, they had this product called propacetamol. And here it is. What they did to achieve water solubility is they took dimethylglycine and made an ester derivative of acetaminophen that's quite water soluble, and that's what they had been using as a parenteral form of acetaminophen. I'm told it hurts a lot when it's injected, and that was a downside. Recently, we've had available to us this new preparation of intravenous acetaminophen, and here's the recipe. In a bag, they put 1,000 milligrams of acetaminophen, about a 4-fold excess of mannitol, a little bit of cysteine, a little bit of sodium phosphate. It's near neutral pH, and there's 100 mils of water. And it's supposed to be given over 15 minutes. And to an anesthesiologist, I consider that to be a pain in the neck. We like to give our things fast. Now, in the package insert, there is the statement, and I quote, "No dose adjustment is required when converting between oral acetaminophen and ofirmev," or is it ofirmev? Not sure, dosing in adults and adolescents who weigh 50 kilograms and above. And that is a true statement when it comes to toxicity, but it is an absolutely inaccurate and misleading statement when it comes to efficacy. And if you look at the papers, and there's a whole lot of papers on this drug out there, invariably the oral dose, if they actually compared it to oral acetaminophen, most of the studies are placebo-controlled, but when they compare it to oral acetaminophen, they give the same number of milligrams both orally and intravenously, and that makes no sense. It's not a fair comparison. The bioavailability of acetaminophen is complicated. For a single dose of your typical 325 milligram tablets, the bioavailability is about 2/3. The bioavailability gets up to about 90% once you exceed about 1 gram. And so as you increase the dose, you increase the bioavailability. But the problem is the label specifies a maximum dose of 4 grams per day for both the oral and the IV formulations, which makes absolutely no pharmacological sense. Now, we do know that lots of people are worried about the problems with acetaminophen-induced liver toxicity. And my understanding today, acetaminophen toxicity is now the 3rd most common cause of needing a liver transplant after alcoholism and hepatitis. So the accidental ingestion of too much acetaminophen is a problem. But to us pharmacologists, we should be demanding studies that compare truly apples with apples, meaning that if you're going to compare the oral dosing with the IV dosing, not only should we see some correction for bioavailability, but we should also be looking for blood concentrations, looking at whether or not a patient had truly a comparative dose. And the stuff's expensive. I realize people in Europe get it a little cheaper, but we're paying $32 a dose now in the United States. Also coming down the pike, or have come down the pike, are some drugs that are COX inhibitors. And I swiped this diagram from Goodman and Gilman because I find it to be extremely useful to look at the pharmacology of the COX inhibitors we already have in terms of their selectivity. Because we all use ketorolac, and ketorolac is actually quite selective for COX-1, meaning that, of course, it's going to cause a higher risk of GI ulceration, higher risk of bleeding, lower risk of when used long-term, of cardiac ischemia, and it achieves most of its effect by its anti-nociceptive action rather than its anti-inflammatory action. And a few years ago, when we got our hands on COX-2 inhibitors, we thought these were great because they are very selective for the anti-inflammatory effect, and of course they're more GI friendly because they don't inhibit COX-1 very well, and they're less likely to cause perioperative bleeding. And so we really liked valdicoxib and rofecoxib when we had our hands on it. Unfortunately, FDA took those drugs away from us in what I personally consider to be a misguided attempt to protect us, because, for example, if you look at paracoxib, the parenteral COX-2 inhibitor, people were only going to use it for a couple of days, and all of the data supporting the increased risk of cardiac ischemic disease was based on months to years of therapy. So I thought that was very unfair. But anyway, if you look at this graph, you can see that the commonly used COX inhibitors, for example, perioperatively ibuprofen, is not selective at all. COX-1 and COX-2 are just about the same in terms of inhibition. But I think what's really neat is to look at a couple of the older drugs that were invented before the COX isoforms were discovered. And those drugs are DICLOFENAC and ACETAMINOPHEN. And both of these drugs were found long after they were introduced to our market, were found to be highly COX-2 selective. And I think that is potentially of great knowledge and great use to us. And we do have ibuprofen available as a parenteral drug. It's not a particularly creative solution. It didn't take a lot of creativity to get the stuff into water. One vial contains 800 milligrams, which is a unit dose of ibuprofen. They threw in a lot of arginine as a buffer. It's a whole lot cheaper than acetaminophen at $11 a dose. And as far as I know, hardly anybody ever uses it. We don't have it on our formulary, and my very, very unscientific surveys of my colleagues elsewhere suggest that it's not being used very much. But it is out there. And when one compares parenteral ibuprofen with parenteral acetaminophen, of course, ibuprofen does have much higher efficacy, but it carries along with it some bleeding risk, some renal and cardiac risks, and some ulcer risk, but it is a whole lot cheaper at $11 a dose versus $32 a dose. So I think ibuprofen is a mild solution to a problem solution. But I think what's potentially exciting is diclofenac. As I said, a few years ago, we thought we had paracoxib coming down the pike, and there were quite a few studies that were done in the perioperative period. It was like ketorolac was shown to be a substitute for morphine in mild to moderate pain, and it had significant opioid-sparing activity in severe pain. But of course, we don't have it, and we're never going to have it. But diclofenac is interesting. Again, it was marketed before the discovery of the COX isoforms, and its COX-2 selectivity is approximately the same as celecoxib that we do have available to us, although not in a parenteral form. Now, in Europe, for a long time, there has been a preparation of diclofenac available for parenteral use. It's called Voterol. Here's the recipe. In the vial, there's 75 milligrams of diclofenac. It's got some mannitol, it's got some propylene glycol. You dilute it to somewhere greater than 100 mils, and you have to infuse it over 30 minutes. I consider that to be a problem solution. I think that's a pain in the neck. And so very recently, we have had available to us, and I understand from the rep who's just outside the door that we can now buy it. It was approved last year in the United States, a preparation called Dilaject. I don't really have an understanding why it was approved in December of 2014, but actually didn't go on the market for many months after that. But the recipe for that contains 37.5 milligrams of diclofenac. Here they used a cyclodextrin to get it into solution, and I'm going to talk a bit about cyclodextrins in a few minutes. But this is hydroxypropyl beta cyclodextrin. There's a little bit of monothioglycerol, and it's okay to give it undiluted as an IV bolus. And the first study of this, like many pain studies, was young, healthy people having their wisdom teeth whacked out. And in this particular protocol, there was a local block by the surgeon, and the study medication was 5 different doses of diclofenac, as low as 3.75 milligrams, all the way up to 75. Ketorolac 30 milligrams was their comparator, and they also had a placebo group, and they had 50 patients per group. And it turns out when you look at the dose response curve, 75 milligrams was not superior to 37.5 milligrams, so I'm going to show you the data for 37.5 milligrams. And in terms of the pain relief, based upon a visual analog scale as a function of time, not surprisingly, the placebo patients did not do that well. And when one compares the diclofenac at 37.5 milligrams with ketorolac at 30 milligrams, the onset qualitatively looks to be about the same, and the peak effect looks to be about the same, although again, in this paper, unfortunately, there's not good measures of variability. In terms of the duration of effect, qualitatively, it looks like the ketorolac is giving a longer duration of analgesia. These two curves are not statistically significantly different. However, with a population size of 50 patients per group, that might not have been high enough or large enough in order to detect a difference. In terms of when these people asked for a rescue analgesic, you can see that the lidocaine lasted approximately an hour, and between 1 and 2 hours later, the patients typically started asking for more. And very rapidly, the placebo group patients required a supplemental rescue analgesic. And again, if you look at the number of patients who needed a rescue analgesic as a function of time, it does appear that the diclofenac group at 37.5 milligrams was requiring analgesia earlier than the 30 milligram group of ketorolac. However, that difference, again, was not statistically significantly different. So assuming that we violate the package insert and give it a little more frequently than every 6 hours, I think this does represent a significant solution to a problem solution. When we compare diclofenac to ketorolac, they both have very high efficacy. Diclofenac, and these are all theoretical predictions, there should be a lower risk of bleeding because of its COX-2 selectivity. There should be a lower risk of GI ulcers. The ketorolac probably would have a lower risk of cardiac ischemia, but when it's only being given for a day or two, that's probably not going to be meaningful. And the ketorolac may have a higher risk of renal injury, especially in patients with underlying renal artery stenosis. What we don't know is whether the kinetics of diclofenac really are shorter than ketorolac. I think it's probably going to be the case, but that I think will be easily overcome by shortening the interval between dosing. At the time I made this slide, I did not know what the price was. I found that out a few minutes ago. It's $15 a dose, so it's priced a little more than ibuprofen and a lot less than acetaminophen. Whereas comparison to ketorolac, obviously, ketorolac has less than $1 a dose. So in selected patients, there may be utility for using our first injectable selective COX-2 inhibitor. Ken briefly alluded to the fact that we used to have anesthetics available that were dissolved in this stuff called cremophor. And I thought I'd talk a little bit about the chemistry of these drugs and what happened to them and where they're going. Cremophor is polyethoxylated castor oil. And back in the 70s in Europe, there were 3 different preparations of intravenous anesthetics available that were dissolved in cremophor. There was propofol, propanidid, and ALPHAXALONE. And they were on the market for about a decade and a half, and they were all withdrawn because of the unacceptable risk of hypersensitivity reactions. Interestingly, I was able to find some drugs that we still use in the United States that are, in fact, formulated in cremophor, like the immunosuppressive drug cyclosporin and the antineoplastic drug paclitaxel. And when patients get the parenteral preparation, they are typically premedicated with both H1 and H2 blockers and glucocorticoids to try to mitigate the intensity of the hypersensitivity reactions. And of course, of those 3, propofol in the mid-'80s was formulated as an emulsion in intralipid. So we've got, in a milliliter, 10 milligrams of propofol, 100 milligrams of soybean oil, some glycerol, some lecithin, and sonicate the heck out of it to make an emulsion. And of course, this has been a blockbuster of a success in reformulating an old drug into a newer drug. Unfortunately, when people tried to put propanidid or ALPHAXALONE into intralipid, it just didn't work out very well. And interest in trying to find other formulations kind of petered out for a while after the mid-'80s. And then we might be rescued by cyclodextrins. So cyclodextrins, very simply, are cyclic molecules composed of glucose monomers. The bonds are exclusively alpha-1,4, and the nomenclature of the cyclodextrin depends on how many glucose molecules are put together to form the ring. So an alpha cyclodextrin has 6 glucoses, beta cyclodextrin has 7 glucoses, and gamma cyclodextrin has 8. And of course, there are lots of hydroxyl groups on the glucose molecule, and typically they are modified most commonly either with hydroxypropyl groups or sulfobutyl ether groups to improve water solubility. And of course, we're most familiar with sugamidex, which is a derivative of a gamma cyclodextrin that has 8 glucoses making up the ring. So here's a picture of this is what actually a beta cyclodextrin looks like. So we've got the 7 glucoses arranged in a ring. There are 21 hydroxyl groups hanging off of the glucoses. And in this particular preparation, which is called sulfobutyl ether beta cyclodextrin, sometimes abbreviated SBECD, it actually has a trade name in its own right called Captisol. And in fact, you can learn all about it going to the website captisol.com, where if you are a drug developer, they will be more than happy to help you figure out how to put your drug into their vehicle. And in this particular preparation, about 1/3 of the hydroxyls have the sulfobutyl group, and the remaining 2/3 of the hydroxyls are intact hydroxyls. So that's SBECD. And this is ALPHAXALONE. I'm not going to spend a lot of time on this because Dr. Johnson covered this, I think, extremely well. But ALPHAXALONE, as formulated in this new investigational formulation, has 100 milligrams of ALPHAXALONE mixed with 1,296 milligrams of SBECD. This is actually a 2-to-1 molar ratio. So it's 2 moles of cyclodextrin for each mole of ALPHAXALONE. And it's basically put into normal saline as a 10 milliliter vial. And as you heard, the kinetics are similar to propofol, has less cardiovascular depression, less airway obstruction. It doesn't hurt when you inject it. The question that intrigues me, and as far as I can tell, if this experiment has been done, it hasn't been published. But what would happen if you had an animal, possibly later a human, anesthetized with ALPHAXALONE, and you gave them a large molar excess of the CYCLODEXTRIN? We know what happens when somebody is paralyzed with rocuronium and you give a large molar excess of Sugamidex. The Sugamidex does a very good job of sucking the muscle relaxant out of the muscle, and the patient recovers from neuromuscular blockade very rapidly. My question is, first of all, if you gave such a large molar excess of SBECD, first of all, is it safe? The Captisol website implies that it is. But if we had somebody who was too deeply anesthetized, would we be able to reverse the general anesthetic effect of ALPHAXALONE with just adding a large molar excess of the vehicle? And I would really love to see the results of this experiment that, as far as I can tell, if it has been done, it has not been published. The last drug I want to talk about is PROPANIDID. This is another one of those drugs that was available in Europe in the 70s and early 80s as a solution in Cremophor. And this is the structure of PROPANIDID. And the new drug, which has 3 papers in this month's issue of ANA, was called THRX 918661 and a few other numbers. And I want to spend a few minutes telling you about how this drug came about. Back in the late 90s, I was a consultant for a little company called Advanced Medicine, and I was working on a project that got canceled. And I was commiserating with their lead medicinal chemist, whose name was Tom Jenkins. We both felt kind of bad that the work was not going to go forward. And he said to me, what else can I make that anesthesiologists would like? And I said to him, we need an esterase metabolized GABA-A drug. He said, okay, what does it look like? And I said, well, propofol is a good example, but so is PROPANIDID. And PROPANIDID is already esterase labile. So why don't you try to make a formulation of PROPANIDID? And he said, now I'm going to start with propofol. So he made a bunch of ester derivatives of propofol, and they all worked as general anesthetics, and they all worked as GABA-A agonists. The problem was he was unable to come up with a carboxylic acid metabolite that was inactive enough. And when the ester was hydrolyzed, the resulting carboxylic acid still had too much activity to make it worthwhile to pursue this avenue. So then, after wasting some time, he said, okay, let's try PROPANIDID. And so he could not get it to go into intralipid, but we already knew that. So then he tried a product of medium-chain triglycerides, and it was quite soluble. But the problem is that PROPANIDID is not a particularly potent drug. And between the solubility in medium-chain triglyceride and the low potency of PROPANIDID, it was estimated that a typical induction dose in an 80-kilogram patient was going to take 2 or 3 60-milliliter syringes. And that was going to be a pain in the neck. So he says to me, we need to make this stuff more polar and more lipid soluble, more nonpolar, more lipid soluble, and more potent. And I said to him, okay, you see this thing right here? Why don't you start here and start extending the chain and make it longer and longer and longer until you're happy? Well, that was a very short group of experiments, because very simply changing the methyl group to the ethyl group changed the potency by about 3 or 4-fold, and it changed the solubility in medium-chain triglyceride by about 3 or 4-fold, and voila, he had what he thought was a marketable product. Now, the problem was, the company that named this THRX 918661, they are well known for their dimer technology. That's their business plan. Their first drug was telavancin, which is basically a vancomycin dimer. and they have a very long-acting beta agonist that they're working on with Glaxo that is basically it's an albuterol dimer. And the powers that be looked at this and said, well, it's really interesting, but this isn't part of our business plan. So they put it on the shelf, and it stayed there for a while. And that kind of like under the radar, they sold it to AstraZeneca. And then AstraZeneca picked it up and did all of the necessary preclinical and early clinical studies. So Astra now calls it AZT3043, and that's the name that you see in the 3 papers in this month's issue of ANA. So the formulation that they're using, it's a 6% solution of the anesthetic. It's a 9% solution of medium-chain triglycerides. This is a European preparation called LIPOID MCT, which is a dietary product in Europe. There's a little bit of lecithin, a little bit of glycerol, and then it's put into 1 milliliter, and they sonicate the heck out of it to emulsify it. Lipoid MCT is a mixture of medium-chain triglycerides, all of which are unsaturated. About 90% are C8, C10, with a smattering of C6, C12, and C14 chains there. And in the first of the 3 papers, they did a dose response curve with a 30-minute infusion. They went as low as 1 milligram per kilogram per hour and escalated up to 81 milligrams per kilogram per hour using a BIS endpoint. And you can see the curve here shown in kind of the rust color, which is 36 milligrams per kilogram per hour, achieved a steady state BIS value in the high 40s in this population of people who are unstimulated. So that's probably somewhere in the ballpark of what a reasonable infusion rate will be for general anesthesia in the absence of pain. In the next paper, they did a bolus plus infusion. And first of all, there's some interesting hemodynamic effects. The gray curve is the highest dose, which is a 4 milligram per kilogram bolus, followed by 40 milligrams per kilogram per hour. And you can see in a dose-dependent way, there is an increase in mean arterial pressure, and there's a dose-dependent increase in heart rate. It does not appear that these sympathomimetic effects, or at least in this population of people, are likely to be dangerous, but it is potentially reassuring that the hemodynamic effects are probably not going to be adverse. Not surprisingly, it is a ventilatory depressant compound, and so if we look at the PCO2, the left axis is for the Europeans, the right axis is for the Americans. But again, you can see how egalitarian the Australians were when they drew this graph, right? So the 4 milligram per kilo bolus followed by the 40 milligram per kilogram per hour had PCO2 values of 45 millimeters per mercury, or 6.0 kilopascals. So it is a mild ventilatory depressant drug at a dose that is consistent with general anesthesia in a patient without pain. The thing that concerns me a little bit is this wake-up curve. So here we look at the wake-up, the number of subjects who are now able to respond to a voice command, which I consider to be a good measure of wake-up. The highest dose, the gray curve, after a 30-minute infusion, you can see how rapidly these patients are waking up. This does not look like the kinetics of esterase metabolism. This looks more like the kinetics of redistribution, and I do not understand why this is the case. When this particular drug was used in pigs, the emergence kinetics were quite superior to those of propofol. What we really need to see with this drug is to see how it compares with propofol after a really long-term infusion, 4, 5, 6 hours or longer, to see if the esterase metabolism pathway does convey a superior emergence characteristic compared to propofol in humans, because maybe the humans do not respond to this thing the same way as pigs do. And the third paper, I put this up just because I love this picture. This is a diagram of the recirculatory kinetic model of AZD3043. I am certainly not the person to try to explain what's going on here, but they hypothesize 5 different intravascular, they don't call them compartments, they call them tanks. 5 different intravascular tanks, which I personally cannot really envision, a couple of peripheral compartments, and finally a non-distributive pathway. I love this picture just because it's beautiful, but I freely admit that I do not understand it very well. If Dr. Henthorne, who I think invented the techniques that they were using to come up with this diagram, wishes to comment, I welcome his thoughts. Anyway, so in summary, what solutions do we have to problem solutions? I think dantrolene gets a thumbs up. I think it clearly is going to be easier for us to use it, this new preparation, when the feces are hitting the fan and you're all by yourself in the ambulatory surgery center. For acetaminophen, it's not a thumbs down, it's a thumbs mostly down until we get it into a preparation where we can put it in one syringe and inject it as fast as we can, like the way we like to give all of our other drugs. Ibuprofen, I give almost a thumbs up, but not completely, because there's not a lot of data on it compared to other things. Not a lot of people are using it. So we just don't know enough about how the parenteral formulation can be used in our patients. I think DICLOFENAC gets a thumbs up, the first parenteral selective COX-2 inhibitor. I think that we will be able to find a subset of patients in whom this stuff will be useful. And as far as the 2 intravenous anesthetics, ALPHAXALONE and AZD3043, I think potentially they should get thumbs up, because even if they don't have improved kinetic characteristics compared to propofol, the fact that their hemodynamics may be superior, may render them useful in in a subset of patients. But again, the really ugly guy waiting out in the corner is going to be the person who actually applies the price tag for this, especially for those of us here in America where we are very, very price conscious. We have to try to find the subsets of patients in which something like this will make a difference to our work. Thank you very much. We have a little bit of time if anybody has any questions, and I thank you for your attention.
So, Mark, that was a great talk. Your focus was on solubilization. And
right, which is why I did not talk about any of the etomidate derivatives, because etomidate is not a problem solution.
No, I don't want to talk about that right now either.
Okay, but I wanted you to know that I'm not leaving you out.
No, that's okay, and I wasn't taking that personally. But you didn't mention anything about the impact of your formulation on the pharmacokinetics and pharmacodynamics of drugs. Can you make some comment about whether we should be concerned as we transition from one formulation to another formulation, how we might actually be affecting the effects of our drugs?
Certainly, especially with regard to the cyclodextrins, this is a potential issue. As we know, sugammadex may suck useful hormones out, and there are warnings that if you give somebody sugammadex who's taking oral contraceptives, you may have to be careful and use other forms of contraception. And certainly, if my theory is potentially right, where the beta cyclodextrin could suck the propanidid derivative out of the brain, who knows what else it might suck out? I mean, these are very, very nonspecific suction catheters. And you're absolutely right. If we're going to be using these things, we need to look at drug interaction studies and whether or not, once the drug leaves the vehicle is still there. Is it going to do something else? And with regard to Sugammadex, we know the answer to that is sometimes yes. Yeah, Jim.
Help me look at something on slide 18.
Okay.
This was the rescue time. As you talk about it not being statistically significant between the diclofenac and ketorolac, do we not have the right statistics to have lines that look very different be different?
So this was the figure that I swiped from the paper. And I did not attempt to reanalyze their statistics. I think the real issue is they had a total of 8 different groups. So the figure in the paper is much dirtier because there's 8 different lines here. I just put the 3 lines that I thought were most interesting. And I think with 50 people per group, it's underpowered to discover what I'm mostly interested in.
My fear is that we don't have the mathematics that engineers use when we do pharmacokinetics to look at time-related functions. We're looking up and down and not left to right. That seems to be a consistent thing missing in some of our math.
Yeah, but when one does Kaplan-Meier survival curves, there are clearly statistical tests to look at the entire line and decide if this is different from the line below it or above it. And they applied that test to these data, and they said it wasn't significant, but I think, again, they're possibly making a type 1 error.
Mark, can I
Yes.
put you out of your misery? If you give not the 7-sulfo cyclodextrin in excess to animals into patients who are being given ALPHAXALONE, but if you go to the veterinary preparation, which is a beta cyclodextrin, it's been around for a long time, then it has no effect whatsoever. And that's my contribution from the other university in England, Cambridge, in other words. The vet school there have done it. The other question I was going to put to you, so I don't think that it'll reverse the effects.
It also may then be less toxic in terms of drug.
Yeah, well, you wouldn't want to give the beta, the two hydroxy beta cyclodextrin to man. As somebody who's used all of those drugs over the time, I would have put it to you that having seen all the data for the AZD 3043, there's better options around, and that, as we wrote in the editorial, I don't think we're going to see it coming back anywhere into this world or the next. But I may be wrong.
Okay.
Rob Sneed again. Just to declare a very ancient conflict of interest. I was on Organon Technica's advisory board for 10 years during the development phase of Sugammadex. And actually, this business of interactions is both very interesting and very complicated because you can't prove a negative. It is not possible to conduct an infinite number of drug interaction studies to prove that an unknown combination of different steroid-like molecules won't be sucked out of the eyeballs or some other place. So what was done and approved acceptable to the regulators, the European regulators, was microcalorimetry, whereby you put things together and you look for tiny temperature changes due to the changes in entropy. And then the other addition to it was a very sophisticated set of modeling, because you also couldn't conduct a clinical trial of every known possible combination of an injection of Sugammadex and an injection of rocuronium. And if you read the summary product characteristics, which I just called up on my laptop, it is quite clear that there aren't any known meaningful interactions, that a lot of theoretical modeling and the basic science, which is the microcalorimetry that's referred to, suggests that there is a kind of a non-problem. So I think it's not as bad as you
No,
articulate.
but there is this potential problem. Again, I've never used Sugammadex.
It's theoretical, though, and it hasn't turned out in the other case.
But is there not a warning that if you get Sugammadex, you're supposed to use alternative methods of birth control if you're on an OCP?
It says, for hormonal contraceptives, a clinically relevant capturing interaction could not be excluded, right? No displacement interactions are expected. So,
Okay.
One more.
Just not clear. In the setting in which Gammadex is used, how many patients need birth control?
I don't know, but I guess you could imagine somebody who came in for a very short procedure and then went home the same day. It got knocked up that night. I mean, it's...
I can't imagine, but okay.
I have no idea.
Any more questions? If not, we'll have a break and we'll be back at 10 o'clock. Thank you.